Hi, I'm Jens Chapman, and welcome to the Seattle Science Foundation. We thank you for your interest over the past years in our regular programming, and we will continue to look forward to a great new 2025 program series. As always, we pride ourselves on offering free and widely available high-quality content, and I'm, as a spine surgeon, always very intrigued in learning from this. In 2025, to support our mission, we'll have to charge for CME credits, and this is doable through an all-access pass. This all-access pass will be differentiated for residents and fellows and for attending level or faculty surgeons. So please join us in the future. If you want to have CME credits, please do it through the all-access pass.
And we're live in 5,
4, 3, 2,
1.
All right, good morning. I'm filling in briefly for Dr. Chapman. Today, welcome to the STED Talk, Science, Technology, Education, and Discourse. We have our own Dr. Chapman speaking today on complex cervical fractures, so we're excited to hear from him. As always, we'll start with some cases. So I'll hand over the floor to Oliver, our distinguished fellow from Pennsylvania, Penn State, who will run a few cases first, and then we'll go over to Mosen.
Dr. Chapman, do you want to come up here? Or?
No, you go.
You want me to?
We start.
Okay, so this first case is a fun one that I think Dr. Chapman actually had done a couple weeks back. He's a 70-year-old male, has a history of sarcopenia, osteoporosis, malnutrition, and nicotine abuse. So all the things not good for a big spine surgery, unfortunately. His past surgical history, he had a C3 to 5 posterior fusion. He had multiple low back surgeries before as well. He's a car collector and a motorcycle and car racer. And he basically came in because he was having severe low back pain, neck pain, torticollis deformity. And he had this forward flexion, the kyphosis, and some right tilt of his head. On exam, we kind of spoke about he had severe forward tilt. His head was tilted to the right as well. He was able to lay flat, and his range of motion in his neck and his back were limited just because of the pain and his overall posture. Strength-wise, he was overall weak throughout, notably in the arms and legs, especially distally in the hands. And his muscle bulk was just overall atrophic from his malnutrition and everything else. In his reflexes, he was hyperreflexic. He had Hoffman's bilaterally. He had hyperreflexic patellar and ankle reflexes, as well as tricep reflexes. And he had diminished sensation throughout with vibration and pain and light touch. And at that point, he was using a wheelchair to ambulate. This is his MRI here. Hopefully the video works. Yep. So that's the axial and sagittal. I'll play that one.
Can you just explain a little bit what you're seeing on the sagittal for our audience?
Yeah, absolutely. So this sagittal T2 weighted MRI, and you kind of see this translation listhesis of C3 over 4-5, which is starting to autofuse and just kind of erode into itself, and it's causing pressure, obviously, posteriorly on the spinal cord itself, and looks to be of a failed fusion at C3-4-5, which we can overall evaluate better on a CT. But with that previous fusion, he's obviously starting to translate, and he's having this coronal tilt as well to the right, based on that axial imaging there as well.
Yeah, so this is a significant problem. Okay, so yeah, keep going. I don't want to steal your thunder.
No, that's okay. So I'll just show that again here.
So again, pretty significant compromised spinal cord. Yeah, beautifully done.
And here's his CAT scan. So you see
Again,
that posterior fusion. Sorry, go ahead.
yeah, so posterior fusion failed, hardware kind of loose, there's a probably solid block of bone between C4 and 5, and then there's a substantial anterolisthesis C3 on 4, and end-stage spondylosis at 5, 6, or 6, 7, whatever that is. 2, 3, 4, 4, 5, 5, 6.
Yeah, 5, 6.
Fair?
Yes, definitely. These are his pre-op X-rays here. So you can see that hardware at C3-5, and then on his AP view, you can see that he's tilting over to the right there, and you can see that based on his hardware as well. And obviously that kyphosis that he's having in listhesis. So his diagnosis, as we had already kind of spoken about, he had that failed C3-5 fusion. He basically had this fracture dislocation at C3-4 that's causing this listhesis. He had some very significant myelopathy. He was hyperreflexic. He was in a wheelchair. He had balance issues. He had acquired kyphosis and torticollis, and you can see that on that CT there. He obviously had malnutrition, osteoporosis, significant weight loss, nicotine use, and opiate abuse that he was doing just because he was in so much pain.
Plan. Let's go back to the CT. Dr. Kramer, so I know you're a younger surgeon, and this is, again, something that in our facility can happen any day to you. And I'm sure you've seen this. Dr. Kramer, for the audience who doesn't know him yet, is a neurosurgical colleague, originally trained at the University of Wisconsin. This patient did not come to me for his neck. He came to me for bad back pain. And yes, he's had, I think, 4 or 7 or something like that surgeries there, all in outside facilities. Yeah. But he's in a very precarious head position, and he has some neurologic embarrassment from his neck. But he's actually not, I mean, he's complaining of his neck, don't get me wrong, but he primarily came for his thoracolumbar spine. So what are your thoughts on how to listen to the patient respond, and how do you prioritize without having access to the thoracolumbar spine right now? How do you prioritize care? Here, I'm the surgeon, I see this. Is this a top priority, or can we concentrate on the spine in good faith?
Yeah, great question. I think, the answer is pretty obvious. We need to focus on the cervical spine first. Looking through his history, he's set up for this on multiple fronts: sarcopenia, osteoporosis, nicotine use, other drug use. So it's, given all that, seeing this picture, in part is not too surprising. But I think, it's not uncommon to see tandem disease. Patients come in thinking it's their low back, and you find, brisk and pathologic reflexes, and it makes you start looking elsewhere. And oftentimes we see cervical stenosis as well. From the standpoint of recovering from, episode of surgical care, I think it's almost imperative that we focus on the spinal cord compression first. So I would, counsel this patient that this is priority number 1, and we can focus on the back later.
Yeah, no, thanks for validating that. I could not agree more. I mean, I could not believe this patient is a survivor. And I want to talk about something in this context that goes beyond the x-rays, but this, for me, is an unacceptable cervical spine. I mean, that's he's made it this long and lives kind of by himself and hobbles around in his place amongst his car collection, and somehow functions, yes, with cigarettes, is pretty remarkable. But trying to think about any thoracolumbar reconstructive surgery, I think, is unacceptable also, right?
Totally agree.
So one of the most significant things, as we'll talk about odontoid fractures later, is talking about classifications and this and that. But this patient exemplifies something that we see far more often nowadays, and that is psychosocial factors. He lives by himself. He consumes nicotine. He has a regular diet of TV dinners and whatever, fast food. He does not have a good social network. He lives in his own compound, kind of, and he is distanced from whatever family he's had. So this is a real problem. Dr. Morzinski, so you've come from Pennsylvania, from, again, a great program, Hershey, Pennsylvania. Have you seen these psychosocial factors in Pennsylvania to the degree that you've seen here in Washington State? Is this something that we're seeing more and more commonly now?
I think we didn't take care of the major big city like in Seattle as much, so maybe a little bit less so. But we certainly had a big epidemic of opiate abuse. So we saw a lot of opiate abuse. That was a big issue there, but maybe not to this full extent as I've seen here in kind of a more major city.
Yeah, it's the psychosocial derangement is a really big deal, and again, we'll talk about that in our odontoid fractures later. So psychosocial issues are something that I think, as we evaluate patients, need to take a far greater front and center stage. Any thoughts of what you would have done in your training program in neurosurgery in Hershey?
Yeah, I mean, with this, obviously he's having that fail fusion at 3-5, and he has that 4-5 that's basically autofusing and eroding together. And with that listhesis and with that erosion there, I think you have to do something. You have to do at least a front back, but probably a front back front, and starting from the front to kind of release everything and give the spine a little bit mobility, which probably would entail a corpectomy there at the 5-6 level, remove all that bone, and then go in posteriorly. I think at least to C2, and then down to the thoracic spine, probably T2, and then come back and then put either a large fibular strut or a titanium cage and a plate to hold that in place after hopefully reducing it some.
So whenever we hear front and back or front back front or back front back surgeries, first of all, we can fill whole sessions in national meetings with these discussions, but we dread the turnaround time. So what's the simplest, Rod, if you look at this quickly, the simplest way to do this? Is there a simple, elegant way to just do front and back, or back and front, or are you kind of bound towards a 3-stage surgery?
It does not look like you can do something simple, because you're going to have to go from the front, probably from the back, and then front, and then back again. I don't see how you can get out of this without doing 3 surgeries. There's enough coronal and sagittal misalignment.
All right. So let's see how we proceeded.
All right, so
Yeah, so let's go to that X-ray again. Yeah, this shows go back to that X-ray. Yeah, so this is the X-rays again. So there was if I criticize something, let me ask Dr. Morzinski about that. What did they do wrong in that outside hospital as you look at these images?
Well, I don't see the pre-op images per se, but even on this one, it doesn't look like the hardware is placed perfectly in the span of the lateral masses, so I don't think it's holding where it should. And the coronal malalignment, I don't know if that was pre-op and they didn't fix it to make it end up being worse there, because it obviously is translating above.
Yeah, I think that posterior surgery really looks like it was done indecisively to me. And if you do surgery, especially posterior, doing more is probably better and is less than doing a little and, quote, saving motion segments, which, again, is just a wee bit of a problem. So that's probably my single biggest gripe about this, that this was a very feeble surgery done without much clear conceptual understanding of what's going on in the spine. Just being, Glenn, again, we as surgeons have a lot of power. We should not do unnecessary surgery, but it's obviously a problem when you don't deal with the actual problem decisively enough. That's probably my single biggest problem. And this patient going C2 to T1 or T2 would have realigned the spine, give him a far better mechanical support. And yes, we don't want to do unnecessary surgery. Yes, we don't want to fuse absolutely more than necessary. But for this man, this would have been not even just with the power of retroscope. This would have been a less invasive action. Thoughts, Mark?
I was going to say, at least in my training, we did some more shorter segment posterior fusions. And, I think, I don't know if it was the milk and cheese consumption, but the bone quality in general is better in Wisconsin than it is out here.
That's funny.
So I feel like, you have to take that in the context of, the patient in front of you. If you think you can get away with a smaller posterior fusion. Yeah, I think especially in someone with nicotine use, osteoporosis, some of the things we've already discussed. I think going shorter was a very high risk for failure.
Would we, so Mark, would we wait for this patient to stop smoking and eat some more Wisconsin cheese?
Sadly, I don't think you have that luxury anymore.
Yeah.
Yeah.
All right. So let's see what we did, and let's see what Drs. Kramer and Oskuian feel about our undertaking.
So big surgery here. We actually ended up doing a front-back front. So we went on the right side of the neck anteriorly, did C4-5 corpectomies to break all that bone away and to hopefully give the spine some mobility. And then flipped the patient back prone and did a C2 to T3, removed the previous hardware, did some laminotomies there where he was compressed with C2 to 4, and then flipped back anteriorly and then did a fibular strut between C3 to 6 and then a plate at C3 to 6 as well.
So let's see how we did.
Big operation. These are some of the intra-op pictures here. So you can see the posterior fusion in place and then that anterior fusion with the fibular strut graft between 3 to 6. Obviously much better aligned than he was pre-op. Post-op scout film here, and I have a CT next.
So realignment, full decompression, very painful surgery because it's truly a front surgery. What is this is unfair to you because you're not involved in this case, but what would you anticipate the single biggest problem, number one, and the single biggest problem, number two, in this patient to be? And
intra-op or post-op, I'd probably say dysphagia.
Dysphagia.
Right. I apologize.
Swallowing difficulties.
Dysphagia, yes.
Yeah, so the patient had some swallowing difficulties beforehand. Again, we had to do what we had to do, but how did that work out for this patient?
I think he ended up needing a feeding tube.
He had a temporary Dobhoff tube, and surprisingly, within about 3 or 4 days, he removed the Dobhoff tube. We had counseled him beforehand about needing a J or a G tube, and he actually was able to start eating parade food, and he actually advanced in that. He doesn't swallow normal, but it's going to be normal, I'm pretty sure. The single other biggest problem was disposition. He still has an unstable thoracolumbar spine, so when he's recovered well enough from this, we'll still have to do a substantial thoracolumbar surgery. So Rod, thoughts? Could we have done something different, better?
No. Let's see the saddle. No, I think you guys did a great job. How easily did it reduce posteriorly?
We had to do a fair bit of work anteriorly, so we did a complete corpectomy at one level, so left to right. So we put probes into the transverse foramina to protect the vertebral arteries, drilled all the way through, and then we had a complete left to right disconnect and front to back. And we did simultaneously microscope and C-arm, and then from posterior we drilled out the lateral masses. I think you can see it at C3 and 4, and then the spine became mobile. Wow. And we put the hardware in still pretty dislocated, and then the rods actually allowed us to reduce that quite nicely.
Yeah, excellent result.
So far, so good. But yeah, for me, we showed this case because it's a genuine problem when we under-recognize the patient biology. And again, this will be the talk about, or one of the main themes in the odontoid fracture section later. Patient biology is a hugely important deal. Patient psychology and the psychosocial settings matter very significantly. And we can look at all the classifications we want, but if we don't understand the patient substrate and where they are and where they want to go, we have a significant issue.
And I think you made a great point in the beginning, and I've already seen this here, is that somebody comes in for back pain and leg pain, doing a full, thorough exam to evaluate and figure out that they're actually myelopathic and they're hyperreflexic, to actually look at the neck as the initial issue. It's happened multiple times since being here, and I think that's really important to do.
Yeah, I apologize to this patient. I said, I know you came here for your back, but I am not comfortable putting you to sleep, especially in a prone position, for a 6 or 8 hour complex revision back surgery with a neck like this. And he understood that. I think the pictures speak for themselves, but this is obviously always pretty frustrating to have a conversation about something that the patient did not come for, and more of a very big, potentially risky surgery. So this has so far gone very well, but again, this patient's not done. The neck is out of the way now and healing well, but in a couple of weeks or months, we'll have to proceed with the backside. All right. Shall we go for our next case?
Yeah. Most, do you want to do one of yours? And we can, or do you want?
Sure. So 2 of our fellows are going to an AO course this morning, so they are officially excused. So this is Dr. Mohsen Karami, and he is going to, I want to thank Corey and Ben for putting our sessions together. On short notice, we had our envisioned lecturer had a short notice significant problem.
Hi, good morning. We had a patient yesterday. We done the surgery. He is a 65-year-old male. Chief complaint was weakness of both upper extremities and declining in his function regarding handwriting and his job as a mechanic, and then a little bit of balance disturbances and falling frequently. Had ED and non-perineum as well, and then had chronic neck pain, probably due to chronic odontoid fracture, which was not diagnosed. Past medical history was significant for hypertension and diabetes type 2, non-smoker. Regarding the physical exam, you see here that there was a weakness of both upper extremities. The rating was 4 out of 5. Reflexes were fine, and Babinski was negative, both sides. But Hoffman reflex was present both sides. So this is the X-ray of the patient. So it's a little bit difficult to see, but there is ossification posterior to C2 down to 5.
Mohsen, could you use your cursor to just run that slowly?
Yes. So here, this is not very normal. And then here we can see ossification extending from C2 to C3 and then down to C6 almost. So we run MRI, as you see here. The video, if I can run it. Okay, yeah. So obviously you can see the non-union at odontoid fracture, and then thickness of posterior ligament. So obviously we have to run a CT scan. So on CT scan, obviously we can see the non-union at odontoid, and then OPLL extending from C2, 3, 4, and then 5, probably 6. And this is the axial images. From C2 down to C5, 6. Okay, a summary, 65-year-old male, neck pain and both hand weakness, falling frequently, positive Hoffman. What's the plan?
So go for what's going on with the odontoid? What's the problem with the odontoid here?
Yeah, so there's a non-union, but wasn't recognized in the past, no diagnosis done.
Is this a non-union or is this something else?
Could be os odontoidum.
Now, you've done a pediatric fellowship. You give me the call. You make the call.
Yeah, so os odontoidum could be one of the diagnosis, differential diagnosis. But
why? I'll tell you something. Why is this a os odontoideum? I'll just give it to you like this.
Yeah, because of the round edges of the fracture, and then the size of that is very tip of the odontoid. So obviously we cannot say 100% this is because of a misdiagnosis of the fracture or
I will tell you, it's 100% an ozodontoideum because this is a triangular, so it's trigonal odontoid tip, and it's fully marginated off. There's a large defect zone. It's a cartilaginous defect zone. So this is 100% an ozodontoideum. This is not a non-union of an old fracture. The question is obviously, what is an ozodontoideum caused by? Is this a birth defect? Is this a in utero fracture of the odontoid? This is an onloggy problem of the synchondrosis. We don't know that for a fact, but this is manifest here in ozodontoideum. And the further secondary findings are that this patient has a very large hyperplastic anterior arch and has that very large posterior arch of the atlas. For some reason, there's a stress transfer that takes place signaling-wise in early adolescence. So they get this secondary, very unique hyperplasia of the atlas. So this is an unstable ozodontoideum. Dr. Skuin, you sure know how to pick your cases. So ozodontoideum plus OPL, I think that I have not ever seen this combination. Have you seen that before?
No, first time.
Dr. Kramer, University of Wisconsin, pretty large Midwestern referral center. Ever seen this combination together?
No, definitely not.
Each entity in itself is significant, and we could talk about the indications for surgery remind us of the age again of the patient, a 64-year-old physically active male, but an ozodontoideum in a 64-year-old is pretty remarkable. Usually these patients come to discernment far earlier. Did that patient never have previous imaging studies?
No.
It's pretty remarkable. So, Rod, how long had this patient been floating around with vague things? Was this just completely unknown?
Honestly, he was doing fine until a couple of years ago, and then his wife noticed that his gait was getting unstable, and then he fell, and then he kind of had a central cord type event, ended up in the ER.
So it was an incidental pickup in an ER?
Yeah.
After a fall?
After multiple falls, and then his wife couldn't figure out what was going on.
So sorry if this is so repetitive, but I have to say, for me, this is one of my pet peeves, as you know, the the lack of recognition of myelopathy.
Yeah.
Starting from anybody who basically treats medical conditions, certainly spine conditions, and then ERs, and it goes into medical schools. I mean, if we did a poll right now at the University of Wisconsin with medical students, just a flash test, and tested very basic knowledge about myelopathy, how would that look? Medical students at the University of Wisconsin.
Oof, I want to say good because my training was good.
No, not in neurosurgery. I'm talking medical school.
Yeah.
In medical school.
Yeah. We definitely talked about it.
Okay.
In fact, I think Dr. Trost gave us that lecture. I still recall that lecture. So
That's good. I mean, at the University of Washington, not throwing shade at my previous institution, this would have not looked good. And again, it's just amazing because this is the most common form of spinal cord injury is myelopathy.
Yeah, the patient this morning, I just examined the patient. So he said that I'm walking like a drunk patient, like the drunk man. So it could be one of the earliest symptoms.
It's pretty remarkable, isn't it? So, and so then OPLL, is there critical cord size, Rod? And are there patients with OPLL who have no myelopathy?
I mean, typically, this is kind of the classic OPLL where you can start to see calcification at the starting kind of behind the vertebral bodies. But in this case, I think what was interesting is, just how rapidly this patient progressed. But for me, I don't think there's any critical cutoff. I think like 6 millimeters, 7 millimeters, 8 millimeters.
Yeah, 7 millimeters cord signal changes. Yeah. For what we saw in the AO myelopathy study, when we looked for radiographic predictors, I want to really shout out to Dr. Michael Feelings in Toronto. If we had anterior-posterior cord compression, So the pincer effect with little CSF space, that was prognostically terrible. There's just very little that the cord could do. And again, this must be like 5 millimeters. I don't know, but it certainly looks pretty bad, prohibitive. Yet at the same time, it amazes me. I have a fair number of patients who I've followed over the years. We've done fall prevention measures. We've done careful balance testing on them. They have to go to PT. They have to show once a year and do a daily self-test that they are well balanced. I have a fair number of patients who've adopted a low-risk lifestyle and who have not deteriorated. But the natural course history of this relative to the size of the canal is poorly understood. All right, Mohsen, so you know what was done and you're involved with it, and I will ask Dr. Kramer what he would do. So you have an ozodontoideum and you have OPL with myelopathy, and it's a multi-level problem. Thoughts?
Yeah, it's got to be a posterior approach and long segment decompression and fusion. The question is if you include C1. And I guess I'd kind of like to maybe it's some dynamic imaging, kind of get a better sense for, what's going on at the odontoid.
So, yeah, obviously we don't have all the images here. I think that you have to address both. I would address the ozodontoideum, and this requires a C1, C2 arthrodesis. I would actually do a facet arthrodesis there. And I'm just curious to hear whether Dr. Oskuian will, as expected, sacrifice the C2 nerve roots and do a full open facet arthrodesis. And I would give this patient a C1 to C7 or T1 posterior fusion with a wide laminectomy, undercutting C2 all the way down to C7. Rod?
That's basically what we did.
We have concurrence.
Yeah. So
that is beautiful.
Yeah, we done.
I mean, the trouble with this case was, how much of a laminectomy, and I think you and I talked, and I just was like doing the C3 to C7 laminectomy was the right call.
I think, giving the cord escape space, even one level above and below, we have all kind of adopted the same philosophy here. We like to try to preserve the C2 spinous process as a critical anchor point in case you ever have to go to the occiput.
Yeah.
It's a godsend to have a C2 spinous process there for that.
We actually went to C7.
That's perfectly fine. And
I think the Kuntz, where you have I think in the past, part of Charlie's, work, I think most people did small lammies. But I think Jens, I think taking as much bone off as you can and letting the cord drift backwards is the way to go in a case like this. Believe it or not, I've seen people do laminectomies on these cases, and I don't think that's long-term sustainable with OPLO because it continues to grow unless you fuse it.
I could not agree more. Again, the key thing is that we now know for a fact that OPL is an inflammatory disease. It's a genetically mediated disease that responds to traction on the Sharpie's fibers in the ligament attachments to bone. And so if there's a signal that basically pulls on the ligaments, they want to turn that into bone. So allowing for ongoing motion is not a good thing. And I'm a laminoplasty fan, as everybody knows. I like to not fuse whenever possible. But for OPL nowadays, I usually will fuse a patient, and I recommend a fusion based on what we know genetically. And there's no genetic cure for it at this point in time. We need to probably give these patients the best possible decompression and stabilization with fusion.
Yeah.
Any insights for you?
No, that was a great job. I mean, the decision was great. And then no complication.
Did you do a facet arthrodesis? I don't see bone in the facet joints.
Yeah, there's lots of bone.
Lots of bone.
Joints of C1, C2?
Yeah.
Yeah, especially for the next case. Yeah, so if we have signal changes on the biceps on the left side, but after, surgery, I did a physical examination, everything was normal.
Great. Okay.
Thank you.
Do you have one more case, or is this it?
I have one more.
Oh, shall we just go with Dr. Karami for a second?
So the next case was about a 60-year-old female with a history of C4, C7, ACDF done in 2021. She had the kind of radiculopathy and myelopathy, and then about 2 weeks ago, a surgery done like C7T1 posterior cervical laminopharaminotomy. But 2 days after the surgery, she started having feeling of very severe right hand pain, right arm pain, radicular type of pain. So was put on Dilaudid 4 milligrams for 4 times a day or 6 times a day. Tylenol, meloxicam, diazepam, and many other medications, but no improvement. In terms of physical exam, so on the right side, you see here there was, obviously dorsiflexion of wrist, 3 plus or 3. Elbow flexion, extension, and grip and finger abduction was about 4 out of 5. And then Hoffman reflex was negative both sides, and Babinski were negative. Japanese score was about 10. And this is the MRI. So this is MRI done after the second surgery when we see the patient in our clinic.
So, Dr. Kramer, you, I don't think know this case, but what's going on here? So there was a ACDF done, and we have no images for that, all done by outside doctors. And this was a pretty substantial C4 to 7 fusion. The patient did not have normal swallowing afterwards. The patient works as a chef, so this was a little bit problematic for the patient, but nothing wrong with that. And the patient then develops, lo and behold, I don't know what you saw, Dr. Karami, a bit later, a disc herniation below. Not a huge surprise, right? So how do you proceed with that? This is a distal junctional failure, if you so want.
What was the pre-op images look like?
This is
Before the ACDF?
yeah, before ACDF, I don't have it,
Was
but
it
this is
cervical myelopathy or radiculopathy? Or?
yeah. I don't have it, but this is the MRI before the index surgery. That means posterior C7T1 hemilaminectomy and foraminotomy.
So what are your thoughts about trying a foraminotomy at C7T1,
T1.
which is per se not a bad level for foraminotomies. That's a pretty wide area of the spine. But with the caveat that there's a longer fusion above. Is that a meritorious thing? I don't want to pre-bias you, but just putting yourself back into, let's say...
So I would agree that this would probably be a form of distal, junctional failure with that disc herniation just below the construct. You're right at the cervical thoracic junction, so that biomechanically it's an area where, you're going to see a little more stress, especially with a longer construct just above. I think it depends on the pathology. In this case, it looks like most of that compression is anterior. So by doing a posterior decompression alone, foraminotomy, it's oftentimes extremely challenging to get that anterior pathology, that disc herniation. And, I think, if you do opt for that route, I think there's counseling the patient, you have to expect that, arm pain may not recover very quickly. It can take up to a year sometimes for arm pain to improve with a posterior decompression only. So sometimes it's not palatable for patients, especially if they're in extreme pain and uncomfortable, unable to function.
Rod, hypothetical alternate universe. This patient comes to you, has a distal junctional failure, pretty sizable, I think very substantial disc herniation, C8 radiculopathy. Nobody likes to go on the front of a surgery again, but what are your thoughts? How would you treat this, assuming the patient has failed appropriate non-operative care options?
I mean, I think we treat these patients all the time, and I think this would be a great candidate for an ADR. I wouldn't go from the back because you've got that long construct. I mean, it's not gonna work. I mean, you can't take out a big paracentral disc posteriorly.
Now, this patient has a plate that goes pretty far to the disc ridge. What implant would you trust to be strong enough to hold mechanical forces of a 3-level fusion at the cervical thoracic junction?
I think this is where, again, the great Vince Bryan, who was actually a neurosurgeon here at this hospital, designed, the first kind of concepts of, he kind of put a lot of thought into constrained, unconstrained, and I think this would be a great one for a semi-constrained or a constrained disc. I don't think having an unconstrained disc here would be probably not something that I would do. So, and the 2 screws, usually with the middle keel, you can just put it in. I mean, if at worst, you can take the plate out.
So you'd advise the plate be prepared for a full plate removal or cut the plate off distally. I've seen that done. Mm-hmm. And you'd use some form of a keeled implant.
Some sort of keeled implant. And then now there's that mini keel in that new version of the Pro Disc. So I think that's a reasonable option. I don't know what your thoughts are, Jens.
I like that. I've done it a couple of times. Some insurance carriers don't like it. It's theoretically off-label, so I tell patients that.
That's what's crazy.
The surgeon in question chose to treat this differently, right, Mohsen? So what was done?
Yeah, so basically, because of the recurrence and the CSF leak probably, we done a 2-part surgery. First was C7T1 ACDF, so removal of disc and killing the space, especially on the right side, this herniation. And then part 2 of surgery was C4T2 instrumented fusion from back. And then right C4 laminectomy, facetectomy, C7T1.
So, Dr. Kramer, do you think we're crazy? So we went from the front first, ipsilateral to the previous incision. The patients had actually multiple neck surgeries. She had 1 surgery for this ACDF. She also had a thyroidectomy. And she also had a left-sided parathyroidectomy. So we did not have the opportunity to do a full laryngoscopy first to check for vocal cords. She had mild dysphagia going into the surgery. She had recovered somewhat, but we did an ipsilateral right-sided carotid exposure to have the best possible esophagus visualization and release, including the recurrent laryngeal nerves. And we were able to brush that aside. And we did an anterior cervical discectomy first. We were able to put 2 pins in, one around the plate, one into T1. We had a good manubrium clearance. We did not have to incise the manubrium. And we did a very controlled, actually, microscopic discectomy. So what do you think with that approach of going anteriorly first? And could we have just left it there, or are we too aggressive, yet again, that same old question, by going to the back also?
I think this is a great approach. It wasn't my initial thought in terms of treatment, but it kind of, it does 2 things, I guess. From the front, you're not worrying about taking that whole plate off, which again, with dysphagia and other concerns in this patient from previous thyroidectomy, I think it adds a lot of risk. So you can do a more minimal approach from the front, actually directly decompress that foramina and get her feeling better. And then, I don't think unreasonable to fuse down through the junction because if you did a discectomy alone, I don't know if that would provide a durable repair for her.
Now, if you go back to the pre-op CT, Mohsen, the one thing that we actually saw on the CT, and did you have the video there? Can you pull through
No,
the sagittal?
unfortunately.
So she actually had a C7 spinous process fracture. So when the previous surgeon did that decompression, they did a pretty much complete facetectomy. The patient does not remember a significant fall, but remembers a snapping sensation when she came home. This is a day surgery. Wow. And it's sad we don't have that image. We have to get that for the next time that we show this case. but she actually had broken her C7 spinous process, and that's what we found. And when you look at the MRI, you can actually spot that a little bit now. So there's this weird fluid collection, and we were worried about this being a CSF leak. We're prepared for this both anteriorly and posteriorly, but there was no CSF leak, but she actually had a broken spinous process at C7 in retrospect. So she actually had a iatrogenically enhanced, I have to say, flexion distraction injury. And so this was actually fluid. We cultured it, it's negative, no CSF clinically. But this was a actual flexion distraction injury after a facetectomy. So far she's doing quite well, but here again, nobody likes front and back surgeries. I keep patients intubated usually just as a precaution. A flip in our hospital where we have very good hospital assistants still roughly takes about an hour from closure to prep. Rod, is that your experience? 1 hour?
I think that's pretty fair.
And we try to have everything organized. We have a second table. We have a whole host of people who come in and to help. It's a very organized thing. We have a good anesthesia group that handles all the lines. We've not had any line removals or anything like that. But I don't know, Mohsen, what's your experience with flips? Is it relatively well handled here? Have you had faster
Yeah, it's
flips?
great. It's great for sure.
But still, it's an hour roughly until you have the patient ready to go for the next step. So it's a big hassle, but
But much better than other hospitals, I guess.
yeah. But I still have to say I felt that front and back was the only way to go, and this was validated through the flexion distraction injury that this patient basically had sustained somehow, just a stress fracture. So far so good. No overkill, Rod?
No, I mean, what are you going to do? There's not much. It's like a trauma.
It is like a trauma, yeah.
I mean, we've seen actually people dislocate. Jens and I have, like, very quickly. So it's not a benign thing to do, a laminectomy.
You could
posteriorly. I mean, we had a couple people where,
we'll see one in a second.
Yeah.
So the last case that Dr. Morzinski will show is a collaboration of us, so we'll have to pimp Dr. Kramer on that. But the telltale thing on her was she had her head tilted forwards pretty badly. She could not raise her head up. And she had, interestingly, not been put into a neck collar, which I thought was interesting. So she loved having a neck collar. And it's not what you expect after formiotomy. Yeah. Yeah, but her head was, her chin was on her chest when I encountered her first, and we said, get her a neck collar. And there was a substantial swelling over her neck incision. It wasn't draining, no headaches, but yeah. Mohsen, any thoughts from your end, learning sites?
So my question was like the access to C71, was it?
The key thing I don't think we can see on the present images. So I look at the CT and MRI sagitals to look for the manubrium, and I look for the manubrium entry angle. And here you have to be prepared, and this is why we did a carotid exposure. We want to have a very clean release of the esophagus, and we want to be medically prepared, or surgically prepared, I should say, to remove the whole plate and to cut out part of C7 to have a better access angle. But as it was, we had a clean, straight, coaxial visualization of the disc space. And we could really, I think the CT shows it to do a very nice anterior release. It's literally an anterior osteotomy. We took out the uncovertebral joints totally. And we're then able to spread C7 straight onto T1. So we could put a pretty sizable, I think it's a 9mm allograft and no anterior plate. So, all right.
Thank you.
Thank you. And now we have, last but certainly not least, Dr. Morzinski, who's going to segue us into today's topic of odontoid fractures. And I want to thank our fellows for doing these case preparations last night. They were all in the OR, and they did late night work. And it had to be two only. The two others are, as we said, excused. They're flying to an AO meeting in Palm Beach, Florida. Our thoughts are with them.
Wow. Prayers for them.
That's rough.
Good times. I know, rough times for them. So this case, this is a just sad gentleman, sad case. 75-year-old male with a very, very long medical history, CAD, aortic valve replacement, AFib, on anticoagulation, hypertension, sleep apnea, diabetes, peripheral neuropathy, you name it, he had it. He had a fall and had an odontoid fracture, and then went to an outside hospital and had a C1-2 fusion. Unfortunately, after a month after the fusion, he had developed some neck pain, and they got a scan at the outside hospital, and he had a post-op fluid collection, so he was taken back for a wound washout and revision. This wasn't just a hematoma or a seroma. It was unfortunately an abscess with positive MRSA. The hardware was loose, it was eroded, and so at that time, the decision was made to remove the hardware and hope that he did fine, and just place in the collar. And then he, sometime later, had what sounds to be like a minor fall. He became acutely weak, imbalanced, unable to walk or stand, and then eventually saw us. On exam again, he couldn't stand, he couldn't walk, but his exam here, he had diminished strength throughout. So in his arms, his legs, everything, he was 3 to 4 out of 5 throughout. But again, couldn't stand, was completely off balance. He had decreased sensation throughout as well. And 3 days prior to us seeing him, he was up and walking and overall doing okay. I think hopefully this will play here. Yeah, this is a CT scan. So he has a lot of problems here. You can see that C1-2 is basically eroded, and in essence has a fracture there. And you see the C2 is just gone. There's almost no bone there on that side. And there's the axial. I can play that again here.
There were 2 or 3 previous surgeries attempted there by outside doctors
Yeah.
for an odontoid fracture.
But that bone is just completely destroyed.
So the hardware was removed after an infection, and
Yeah.
it was just basically, from what I gather, this is done all at an outside hospital. The patient was told that there's literature that suggests that you can just ignore odontoid fractures. And was this an option in Hershey and the neurosurgery department? Odontoid fractures, just ignore them?
No, definitely not. Definitely not one to ignore. Definitely not one like this, especially. I mean, this is clearly unstable in so many ways, not just with the dens, but with C1 as well. I mean, there's so much erosion there. That bone is just not strong enough to withstand anything at this point. So there's no possibility to keep this patient in just a collar and hope for the best.
Yeah, so Dr. Skur and I treated this patient together, so it's unfair to ask him for his opinion about things, but I'll still ask you, so what, and then we'll go to Dr. Kramer. So this is obviously devastating, like 2 or 3 or more surgeries, and then everything was taken out because of an infection. The patient was basically left to their own designs because he is old, and you can live with an odontoid fracture. What are your thoughts on that?
I mean, I'm not sure that's going to work out very well, especially if it was infected. You know, I think it's. I don't
That's
think.
the MRI.
Yeah, I don't think that's. Unfortunately, I think once you fuse someone and then they get an infection, I don't think you can just take out the hardware. I don't think that's the problem.
Looking back, we did not have all the old images from the outside facilities, but what do you think went wrong? Was it just poorly placed hardware? Was there no biology created to create a fusion? What went sour?
I think it's a combination of both. You know, I think when you go posterior only in someone who is medically complicated, they have bone quality doesn't look great. And there's pretty significant coronal sagittal imbalance. And then, I just think someone like this, they're going to have a hard time healing. And then on top of that, you throw that they probably aren't going to be mobile, and, it's just a setup for having complications.
Can you go if you look at those sagittals, it's actually interesting because this patient fell. I think you remember that. He fell out of a sitting position and banged his head and had a quadriparetic episode. And basically, this patient had like a craniocervical dissociation there. He was completely unstable in his craniocervical junction. Thoughts?
It's a terrible situation.
It's always a bad
Terrible
sign
situation to be in.
when you can see 2 levels on one axial
exactly.
scan.
There you go. Yeah.
So, I mean, there's pretty significant rotatory subluxation there.
Mm-hmm.
I mean, people don't realize, but the amount of forces that go in between the occiput and C1 and C2.
So Dr. Kramer, so this is now what I would call a Charcot arthropathy. So there's a neuropathic arthropathy where there's amorphous bone formation mixed with destructive bone, so lysis and osteoplasia are in close juxtaposition. And basically, the joints have lost their normal spatial relationships. So there's no connection of the cranium to the cervical spine anymore. And this is an intellectually extremely capable individual in charge of their own business and quite disabled outside of neck pain, functionally also now. So thoughts, is there any chance of repairing something? Is the fact that the patient's last surgery was a debridement for a bad infection prohibitive towards a new reconstruction?
Sadly, I don't think you have an option to go in and attempt another C1-2 fusion. I think you're obligated in this case to go to the occiput, just given the amount of bone destruction. And, at least from what I'm seeing on these images, it doesn't even look like there'd be a decent corridor to even get a good C1 screw in. Unfortunately, I think we're looking at occipital cervical fusion for this patient.
All right, Dr. Mrozinski, so what was done?
All right. So, yeah, I mean, I think in this case the points are well taken. That he obviously has this failed fusion, but he also has all the bony issues down low, right over at 3, 4, 5, 6. So, taking that into account, these are his diagnoses of the failed C1-2 fusion. He basically had basilar invagination, the erosion of those bones, sublux. So because of this, we ended up doing a pretty big procedure here to try and fix this. This was an occipital to T2 with a C1 LAMI, and then using fibular structural allograft as well to bridge that gap between the occiput and C1-2 and try and provide some sort of structure for arthrodesis. These are some of the intra-op images.
So Dr. Skui and I did this together.
Yeah.
And we actually spent easily an hour on our CAT scans looking for any residual bone elements that we could still put screws into. And I think we did a translaminar screw on one side.
You did. I have the CT, yeah. Mm-hmm.
And then we did a C1. We did a C1 screw on the opposite side. That was all the reliable bone we could do. We did a CT angiogram on the patient beforehand to make sure that we had a viable vessels and understanding of what's going on. And so if you go through it, so we did.
And there's that translaminar.
So just for the record, I am very leery to do craniocervical fusions these days. I try to preserve the craniocervical junction, especially in elderly patients, so that you can have a downward gaze. It's a very disabling thing to go through. And we're talking about odontoid fractures today. I am very regretful to see a lot of people with odontoid fractures getting craniocervical fusions. And frequently when patients come to me, I look at them carefully, but I actually take their hardware out and just give them a C1, C2 arthrodesis. It's very doable if they come to me in a timely fashion, haven't fused yet. Many patients have a non-unit because they did not have a quality fusion. But this is an exception. I would not have seen any reasonable opportunity to do this. And Rod, you and I worked very hard on releasing the C1, C2 joints, right, so that we could reduce them. But once we had them reduced, Dr. Skuyten changed my life. He introduced me to the power of Gardner-Wells tongs, not any complex rigid Mayfield or Doro head clamps with frequent scrubbing, unscrubbing. The GW tongs are actually perfectly fine. If properly placed, you can get a very nice realignment and disengagement once you have the adequate surgical release. How'd you come up with that idea, Rob?
I mean, honestly, it's something that I picked up in New Zealand because there the orthopedic surgeons and the neurosurgeons almost never use. In fact, for the craniotomies, we wouldn't even use Mayfield clamp. Mm-hmm. So we would just use a gel roll. And then, like, if you're doing an aneurysm or temporal lobe case, you can actually maneuver the head. It's actually... I preferred it, and then we did some pediatric cases where they use Gardner-Wells tongs, and it's not something I came up with, but it's something that I was like, God, I just kind of questioned our practice in the United States. I was like, why are we? And then when I was in Virginia, we would get like scalp lacerations all the time, and so that's when I kind of shifted. Mm-hmm. But psychologically, it's hard to make the shift unless you've done it for a while. So, but yeah, I mean, in New Zealand, we would not, for brain aneurysms, brain tumors, we would not use a Mayfield clamp.
I must say, something simple like that, you changed my life, because I was one of those Mayfield, and then here Doro clamps, and then scrubbing in, scrubbing out, retilting the neck. And even for complex necks, all these necks that you saw here today were done with GW tongs. And the only thing you want to be cognizant of is where you put the tongs and how much weight you put on.
In fact, it's probably a good paper for the fellows research because it's still done on a very small scale in the United States.
Tell us about Hershey.
I think I've been talking to you about it. I'm amazed that the simplicity of the Gardner-Wells tongs and how it shaves time. And everyone, I mean, anesthesia, nursing, everyone is a lot less stressed out when you're doing GW tongs versus pinning. So I'm very impressed with the complexity of cases that we can do here with just a GW tong. So it's been great. It's been great seeing that. We did not use them before. It was always complete pinning in Mayfield, and then either with the Levo or with the regular bed. But the GW tongs are great.
Yeah, we're going to buy this. I'm not going to mention the product name. Hydraulic head lift. I was all in favor of that because we had so many times where I had to unscrub to realign the head intraoperatively. It was actually a ritual of the surgery, and it's gone. Again, these are all pretty bad neck cases that we saw this morning, right? None of them were done with anything but simple GW tongs. So, all right. Thank you, Dr. Marzinski.
you.
And thank you, Dr. Karami, for jumping into the fray. And thank you, my partners, Dr. Kramer and Dr. Oskuyan and Dr. Abdul-Jabbar. I want to also recognize our supporters, such as Dr. Randy Davis, Dr. Luis Cartavaro, and others who are here this morning and who support us. We had a guest speaker who on very short notice couldn't make it and called us, and so we're always happy to jump in the breach. And we have a large number of topics we can talk about, and I asked Dr. Oskuyan, and he said, let's revisit odontoid fractures. Now, I've talked about this before. I apologize to anybody who's heard elements of this talk before. It's a little bit different nowadays. And one promise right off the start is I'm not going to bore you with endless reiterations of classifications. I think that you'll see very rapidly what the gist of this message goes on. The cases that our wonderful fellows presented this morning, I think were a great segue to this. In terms of conflicts of interest, I am heavily conflicted with AO Spine North America and the Global Spine Journal, and I'm a reviewer for all sorts of larger journals. And I also work for Providence St. Joseph's Healthcare System in a number of capacities, not just as a surgeon. Commercially, I have conflicts of interest, but these, I think, will not apply here, but I have a number of commercial co-interests. I want to thank our fellows again in this new academic year. Hagai Amsterkhan and Mohammed El Hoshemi are in a plane right now to lovely Palm Beach, Florida, to participate in an AO North America course. And so I want to thank Mohsen and Oliver for having jumped in the breach. And last night, done this. I circled out Mohsen because I didn't have enough pictures of him, I realized, and he's being taught by the great David Skaggs. But it's a very exciting group, and I'm very impressed with their harmony and creative, in a positive way, intelligence. And I love the new swag. Thank you, Corey and Alexis, for the nice new CL Science Foundation swag. So this talk is about aging. This is a talk about the silver tsunami that we're engaged with and aging. And I'm an aging person myself. I fit into that 65 plus demographic now. And what I've been fascinated for many years with now is the difference of aging. The person on the top left could be 65, could be 60. The lady on the right, you have no idea how old she is chronologically. I took this off the web. I don't know who she is, but this patient could be 100. This patient could be, again, in her 60s. And there are a lot of, especially Western countries, that are really overaging dramatically. So we have to ride this wave of a very profound changing demographic, or we will get crushed by it. And again, this phenomenon of aging and what it means has significant socioeconomic and healthcare economic derivatives. It's little known that by now, geriatric falls, this is not a funny slide, this is a sad slide, that geriatric falls are the second most leading cause of death in America. So this is actually a major population health problem and a crisis. And again, there are multiple factors. You saw four, I think, pretty shocking cases this morning where ill health of the patient led to a number of factors: osteoporosis, arthritis, poor dexterity, poor balance, poor posture, poor muscle tone, et cetera, the list goes on. And patients fall, and then they break something. And this is a real-life case. This is a 95-year-old female who lived by herself and crashed her car at 60 miles an hour. She's neurologically normal, has no head injury. She has a odontoid fracture right here at the waist. There's also an atlas fracture in there. So these are real life scenarios. Question to you is, Dr. Kramer, you're a young attending here. Your microphone response is needed. I'm not going to give you a resolution of this case yet. What would you do? I mean, this is a 95-year-old patient. If you post a 95-year-old patient, whether it's in Wisconsin or here, what's the response of the anesthesiologists?
It'd be a Ferrari. It would not be great.
They would not. They would question, what is this young attending doing? Is he reckless? But again, what they don't see is this patient lives independently. This patient actually drove her own car until it crashed. Now, one thing is she should probably not drive anymore, regardless of what. But this patient signs her own checks, is very independent. And these are scenarios that we're seeing more and more often. Patients who live in their 90s and who have an agenda, and they're entitled to have an agenda. So I always like to show this because all those who are in the spine care business like to see this. We have 28 bone segments, plus minus a couple, depending upon dysplasia, 23 discs, 53 joints. This is a large-scale business project. The spinal column has many, many potential failure points. And of course, in this talk, what is the single most important vertebra? The answer is quite clear. It's the smallest bone segment right here at C2. So do we actually need the odontoid? This is a comparative anatomy picture. This is the dens of a mammoth, and you can see how in other species the odontoid was handled in mammalians. This is a very robust, extremely strong bone that is probably not going to fail, even if there's a head-to-head ramming or a tusk-to-tusk battle. The human odontoid is comparatively extremely small and has a very well-developed waist. That's this little narrow zone right below its head. And again, it's an integral part of the craniocervical junction, which allows us this great head motion. We all know that 50% of our head rotation and extension flexion comes from occiput to C2. So it's a highly mobile unit that is heavily reliant on an intact osteoligamentous unit, and the odontoid is the key element here. Now, why would I put up this hang loose sign here, Oliver? That's the comparative size of human beings' odontoids. So some people have an odontoid that basically is small finger size, and others have a thumb size one. So I always like to point out the odontoid in human beings is between either a small finger size or a thumb size. And that's matters because as we'll talk about surgical strategies, understanding what the actual size of the odontoid is beyond fracture morphology matters. We did this study eons ago, literally a quarter century ago at Harborview, because it struck us so profoundly how within a very short observation window of 20 years, the fracture population of odontoid fractures had shifted. Odontoid fractures were a fracture of the youth, of highly active people, and like sports activities, reckless people. And just in a very short period of 20 years, this is a quarter century ago, the whole profile of patients shifted. And the glamorous trauma population shifted into a geriatric population. This became a failure point. And again, this was published way back. And the difficulties of managing these patients, I'm going to show on these two cases, and I'm going to really hit my partners here. These are two males. Let's just call them patient C and patient R, and these letters don't represent their actual names. One is 72, one is 75. The one on the right is 75. And my hypothesis, the first hypothesis is age does not matter. The chronologic age does not matter. One fell, a left-sided patient, and a ground level fall. The other one crashed in a mountain bike. Both are intact. Patient on the left, the ground level fall patient, is a regular user of nicotine and methamphetamines and a chronic pain patient on opiates and lives at home. The other one is an extremely active person and a global traveler. What of these things matters? What about the fracture? Dr. Kramer, what do you think about the fractures? You're an experienced attending now. So does either fracture worry you, one more than the other?
Yeah, patient C looks like slightly more displaced. In fact, looks like there's some anterior displacement of the odontoid, whereas patient R looks like a pretty minimally displaced fracture. And the psychosocial makeup of the patient is very critical, I think, in both these cases. The patient R obviously active, probably healthy, strong musculature in the neck, all those things are really valuable and important to know before you come with a treatment plan.
I think, yeah, as we focus on fracture classifications, again, this is both type 2 fracture. Both are minimally displaced, I think one can say. One is a higher energy mechanism, the one on the right. The one on the left is low energy mechanism. The biology of the patient on the left is highly unfavorable. The one on the right is far more favorable. So without knowing anything else about these patients except for this little sociogram that I'm giving you and the phenotypes of fracture here, both are neurologically intact, how would you treat patient R? How would you treat patient C? Would one get surgery? Would one get no surgery?
My general approach is, especially these minimally displaced fractures, give them a trial of non-operative management, placement of collar, follow them. I think, patient R is, in my opinion, a more likely, much better chance of healing this on his own. And you don't burn a bridge in terms of a surgical fixation. In my hands, doing an odontoid screw, I just don't have a lot of experience doing it, so I'd be much more comfortable doing a posterior fusion for these. I guess from my perspective, again, I think I would probably collar both patients initially and expect that, there's a reasonable chance both of them could fail, obviously, but there's also a reasonable chance that, more so for patient R, that you might get some kind of solid fusion there with time.
What non-union rate do you quote a patient like patient R with a non-displaced type 2 odontoid fracture?
Sadly, I think it's probably still 50-50.
Yeah, that's exactly the single, still persistent. Thank you, Dr. Morzinski. He has to run off into the OR. Appreciate you doing the cases on short notice. This is still the quote. So let's look at our own state. One of our former fellows, Dr. Bletcher, did a very nice study in our discharge database, to which we had a subscription at the time. And they looked at spine fractures in Washington State. And what we saw as a big trend is that spine fractures actually doubled relative to population size in 15 years, literally doubled, which was a pretty remarkable finding. So this is, again, a population health dynamic that is profound. And again, when we look at that, what we saw as a subset was that odontoid fracture, so cervical segment 2 and odontoid fractures dramatically and disproportionately rose relative to all other fractures. That's this blue line here. So this was a single fracture location that changed everything dramatically. So the blue line is, again, just to get that graph down clear, the single most responsible segment for this change in fractures. And again, when we looked at a number of variables from this discharge database, spine fracture patients were significantly older than any other discharge patients, and the trend was higher than that of the general population. Mind you, these are tens of thousands of patients that were assessed with this database. And the age group that is most affected is 70 and 80-year-olds. So this is a significant factor for all these things. And these are all variables, and we compare this to distal radius fractures, also hip fractures, etc. So that was a very significant insight for us, because as hospitals are really looking for financial survival these days, I'm not being dramatic here, Medicare is something that is not very well funded and does not allow hospitals to really have a margin, and these yield margins are very heavily threatened, but we, on a population side, have a much higher demand for care, whether it's surgical or not, for fractures. So in terms of surgery trends, again, we saw that C2 and odontoid fractures rising, and surgery for these was also dramatically rising. So we have a phenomenon of increasing numbers of odontoid fractures and surgical needs, which is, again, relatively expensive. One question has always been is, do we really need to operate on these fractures? And let's look into this fracture a little bit more in detail. So fractures over 70 and over 80 are now actually the leading fracture populations for these injuries. And most of them are in this waist area, the so-called type 2 area. Far more females than males, and falls are 90% of these fractures now. Complications were very common, so up to 35% mortality and over 50% complications. So this is a significant thing, and missed injuries are very common. Now, what is the problem with odontoid specifically? Just not only being a small bone. This is an area of physiologic osteoporosis. So as we enter our 6th and 7th decade of life, especially female patients, have a physiologically expected thinning of their cortices and of their marrow. So this is a well-known phenomenon. Mechanically speaking, this is a pivot point. It makes total sense. So this either from small finger to thumb, so the chakra sign applies again. This actually serves the pivot point for the C1 ring to rotate around. Makes sense, right? Now add to this the problem that there's frequently atlanto-odontoideal arthropathy, that's a mouthful, and that the C1, C2 joints actually don't get the same kind of an arthritis. So basically the tip of the odontoid gets tethered to an arthritic process to the C1 ring, but the joints at C1, C2 don't get arthritic. So you have a literal fulcrum failure point that is increasing osteoporotic and subject to any twisting or flexion moment that is not restrained by the adjacent segment. So a fracture is almost preordained once you hit your head. How to classify, I'm not going to go into that, but in AO we spent a lot of time on this, and again, I'm going to just say, in this era, the discussion of type 1s, which are almost non-existent, types 2s versus 3 is almost irrelevant. Basically, all you have to identify is this a osseous ligament injury only, or is there a ligamentous component? Any injury that has a more or less type B, so a C type B injury, meaning a ligamentous disruption, is unstable. If it's a purely bony injury, it's a C2 type A injury and could be contemplated for non-surgical care. If you macroscopically, we published on this years ago, look at trends over decades, we saw that there is, just like what we saw in Washington State with our directed Washington study, a substantial rise in surgeries. These are, again, literally surgeries in hundreds per year in a larger population study that we did with Harvey Smith, who was a great collaborator. Non-surgical care in halos, I'm not going to go into that study. We did at Harvard, we did over 350 patients with halos. They actually did not do as badly as we thought, but they're a lot of hassle, and patients absolutely don't like them. And situations like this on the right bottom are unacceptable. This is what we had to do to the head to kind of put the odontoid into place, and nobody can live like that, right, Rod? I mean, you can't swallow and all that. Now, one of my favorite surgeries is odontoid screws, and I literally don't do it anymore. So this was a big setup. This is surgical precision. This is minimally invasive. We don't have to do any fusion. With a very elegant approach and a very careful setup and closed reduction, we can try to realign this fracture and put a screw across. You usually use 2 C-arms, use a C5-6 approach, and you have to start in the disc space of C2-3 and then put an elegant screw mechanically across. 1 or 2 screws doesn't matter. And again, it's pretty amazing what you can do. The one fallacy that we had was that we could restore full rotation. And the great Benny Jeanneret showed that this is actually not the case. You only have about half of normal rotation left because the joints scar down. But the principle is fantastic. I was always a 2-screw fan, but so it is. So maintaining function is fantastic, and many textbooks have been written about that. The surgical accuracy is very important and impressive, but you have to be very careful how you place those screws, and you have to hope that the bone physiology in here is suitable. I'm going to show you a case of a 41-year-old female who fell downstairs drunk. This patient came to us a little bit later, so we were only involved in the later stages of this care, but she has an odontoid fracture. She fell downstairs drunk. She's neurologically intact. And I'll hack on Dr. Kramer again. So this is a type 3 odontoid fracture. There's an unusual left lateral mass fracture. I'm going to have the cursor on here. So this is a little bit of an unusual fracture pattern, but is this a normal type 2 odontoid fracture?
No, especially with that lateral mass fracture. I think, again, with limited view here, it looks like there's been, other trauma to the subaxial spine as well. So I'd be concerned that there could be some ligamentous injury as well.
One thing that I've always pointed out, and that no classification really does, is the obliquity of a fracture. So this is a so-called reverse obliquity fracture. So the anterior fracture line is lower than the posterior fracture line. It's a so-called reverse obliquity fracture. Max Aby identified that. Is this a good case for an odontoid screw? She's young. You want to not fuse anything. No.
I don't think so.
No.
You're going to slide that piece off.
Yeah, no, it's probably not a good one. This patient had an appropriate vascular workup and there was no vascular injury, but the patient was indicated for an odontoid screw fixation. There was an attempted non-operative care and the fracture kind of slipped off. With simple traction, anatomy was restored. An attempt at an odontoid fracture was made with some difficulties because the patient had a larger chest, so getting the wire down enough was difficult. And if you're very critical, if you look at the starting spot, you're probably not far enough in the disc space, so you couldn't get the screw flat enough. So if you look at this now, Dr. Kramer, if I can harp on you again, what's going on there now? Is this a good screw?
Yeah, it looks like the purchase on the fractured odontoid portion is very minimal.
Yeah, so it's probably going right along the fracture line instead of perpendicularly crossing through. The patient actually healed well, but several months later, the decision was made, and this was then done with us here. We decided to remove the screw. It just did not look good, and the patient actually now, without the screw, has healed her fracture. So whether the fracture would have healed with a halo or not, we don't know, or with a collar. I would have probably put it in a rigid collar in the first place and gotten serial lateral x-rays or talked to the patient about a C1, C2 fusion. But I probably don't think that this is a good case for an odontoid fracture. The point here is that technically this is done well, but it can be very, very hard, depending upon the patient's chest size, to get the screw low enough. And these so-called reverse obligatory fractures are probably not mechanically a good target subject. But she had 2 neck surgeries, and now she has a fully healed neck and is apparently doing quite well. So it's just a caveat about odontoid fractures. The most common failure is that they cut out anteriorly because the screw was not recessed well enough. This does not project well, but on the bottom left CT, you see how this patient failed. And we basically did transarticular screws back then to fuse this patient. So the cutout anteriorly is a really big deal. The single biggest problem of odontoid screws was actually that the risk of swallowing and vocal cord problems, as they published, was much higher, seen on the left-hand side, than with any posterior fusions. Both groups can have it. It's just an age-dependent thing. Thank you, Dr. Karami, for your case presentation on short notice. So anterior surgeries, especially in an elderly population in the upper C-spine, creates far more swallowing difficulties. A breakthrough was Dr. Scoel's and Harm's C1, C2 fixation, where we can segmentally fix it. And in my own lifetime, this has been a complete game changer. We used to do so-called Margall screws from C2 into C1, which are very difficult screws. You had to have an anatomic alignment, perfect execution. There's always a risk of a vertebral artery injury. And nowadays with C1, C2 screw fixation, we have segmental fixation capabilities that allow adaptation to the patient's anatomy and vascular anatomy, and hopefully vertebral arteries have become far less with this. Now, we did another study with, again, Harvey Smith, and we looked at different types of fixation over time. And this has become pretty dramatic because if you look at category 5, those are basically fusions to the occiput became an almost non-existence, whereas fixations with segmental fixation, this is this category 2, became like the most common fixation form. So posterior C1, C2 fixation with a good arthrodesis have become kind of the main standard. And again, this is very significantly reflected in the literature now. So we did a prospective study with AO Spine about different types of fixation, anterior, posterior, non-surgical care for odontoid fractures at 3 large academic trauma centers. We looked at mortality and outcomes. And with this study funded by AO North America, we found that the vast majority of patients, especially elderly patients, actually survived and actually had very good outcomes. But yet again, look at the age category of these patients. It's truly something in the 80s and older. And looking at this, most of these patients actually could go back to independent lifestyle. And surgical treatment, again, showed an increasing preference for posterior fusion. Looking at other factors, hospital length of stay was twice that for surgical patients of a non-operative care, mainly a reflection we found of keeping patients in the hospital and looking how they were doing before they had that placed. The other factor was that a lot of these patients got swallowing problems that goes independent of how they were treated, and we gave them feeding tubes, which was its own problem because they would get aspiration. So the biggest surprise for us was that there was a substantial difference in favor of surgery in terms of survival. This was a very substantial difference. So surgically treated patients had a much better survival chance than non-surgically treated patients and had a better quality of life also. Adverse predictors over time, this has been shown in other studies now also, are old age and mainly concurrent diseases, dementia. One factor that we saw, and that's a big surprise with older patients, regardless of how you treat them, was that they develop a so-called vulture neck. So the Geyer deformity, as Maximilian Reinhold quoted in one of our papers, showed that when we treated odontoid fractures, regardless of non or surgical treatment, they would develop this forward pitched. Here's a non-surgical treated patient. And basically, this is a profound loss of muscle tone. So their sarcopenia would basically drop the head forwards. And this is a single biggest factor in terms of disability for these patients down the long run. So physiologic age was reflected in sarcopenia, and a poor outcome was highly correlated to basically developing this vulture neck, or this forward tilt of the neck. Now, going back to the 95-year-old patient that I burdened you with, Dr. Kramer, your young attending, this is your patient, crashed in a car. You may remember from the beginning of this talk. Living by herself, crashed a car. You're supposed to treat this patient now. She has both a C1 fracture and a type 2 odontoid fracture. What are you going to do? C1, C2 fractures, just to editorialize, have a very poor prognosis in terms of healing non-surgically.
Yeah, so again, I think every odontoid fracture is slightly unique. You have to look at it. And in this particular case, quite displaced. Odds of healing are, I think, even lower than 50% with conservative collar only. Even though she's an older woman, I think not unreasonable to sign her up for a posterior C1, C2 fusion right from the onset, especially given the fact that she's been so functionally independent up until now.
Let's ask our chief of spine. Would you support your young attending in posting a 96-year-old patient in their first month of practice for a surgical fixation?
I think it's very reasonable.
That's what we did. And again, we did segmental fixation, and she actually returned to independent living, and she did not drive a car. The family and we met, and we removed her license. We went a little bit lower than C2 because she had significant arthritis there, but she actually did quite well. So happy outcome. Remember those two cases, patient C and patient R from the beginning? So both patients, per Dr. Kramer's request, got a rigid collar in the beginning, okay? Both were a type 2 odontoid fracture. Left patient, high biologic physiologic risk, slightly more anteriorly displaced. Patient R, non-displaced. Now, 6 weeks later, the patient on the left side with the physiologic problems comes back wearing a collar, nicotine stains around the collar, and has severe neck pain, is actually becoming myelopathic. What's happened there? If you put words to what you see there.
Yeah, it's that kind of deformity, that anterior displacement of that fracture is progressed. The cord has probably been draped over the base of the odontoid there. So this is failure of non-operative care.
So now, what do we do now?
Yeah, you're gonna have to fuse from the back.
So we admitted the patient, we put him into traction. He had a draped cord, and we had no option. We had to actually do a C1 laminectomy, did a C1 to C3 fusion. We got I think a pretty decent realignment of the patient by pulling back on the C1 screws. We did a facet arthrodesis. The patient continued to complain of significant pain, but was structurally fine. We followed him, I think, to about 6 months follow-up, and then would not renew his pain contract, or he violated it. The patient R, who seemed such a good candidate for non-surgical care, came back 6 months later wearing a rigid neck collar. He was very unhappy. He traveled the world as a well-to-do individual. He seems to have been very compliant with it. I can't verify that, but certainly took his vitamin D and was active. But this is not healed. There's a clicking in his neck. There's no myelopathy. What do we do now? Tell him 6 more months? Give him an electrical stimulator?
I think he also bought himself a fusion. So I would do a C1-2 fusion here as well.
That's exactly what we did. Wow. We interestingly iatrogenically displaced the fracture. I don't have his latest follow-up films, but he was actually extremely happy. He literally walked.
How did you reduce that? Did you do traction?
Yes, a simple GW tongue traction per ductal screws prescription, and we realigned him, and it worked like a charm.
But do you put the C2 screw in and then try to reduce it?
Yeah, we put the C1 screws lower.
I've seen you do that before.
Yeah, we put the C1 screws bicortically lower than the C2 screws, put both sides in, put the reduction towers on C1, and then very gradually twist them around until C1 slides
But you
back.
do it at the same time.
Yes,
I've seen
two
you
of
do
them.
that.
Yeah, you have
It's
to
really-
offload it. So you have
One
to,
I've seen you do where you put C2 lower and you put C1 and then you put like a post and then you pull it up.
yep. So both patients actually, the left patient complained of neck pain, but the myelopathy actually vanished. The right patient literally walked out of the hospital and was very grateful. He's actually settled this fracture anatomically now. It's interesting, but healed this very nicely. He's very happy. He was questioning why he was not given a fusion right off the bat. So if I look at the literature, we've contributed somewhat to it. The real question that I still have is who actually benefits from surgery? And I would say nowadays mental capacity scores and a comorbidity index, one that we don't have. We have multiple comorbidity indices, but psychosocial circumstances matter a lot. Optimizing outcomes, again, we had talked about percutaneous trachs in very elderly or PEG tubes, mobilization, no collar. I still don't have a perfect answer because, as Dr. Kramer said, every patient is different. The variety of patients, the variability of patient factors and comorbidities is, for me, way more relevant than whether it's a type 2 or type 3 odontoid fracture. That's an anachronism nowadays. We clearly know that certain fractures do poorer than others. The more it goes into the vertebral body of C2, the better it can be. But again, there are many, many factors. I can't go into the details here. Who dies and who does well, that's still not fully understood. But basically, a decisive early surgery, I have to say, not just because of the studies we were involved with, is actually probably the better part of valor. And randomized prospective care, boy, that'll be a massive study. We took like 4 or 5 years and a lot of money with AO Spine to do our study, which is still considered one of the landmark studies. And it did validate surgical care. Yes, it's a surgeon's bias, but the data was pretty clear. For me, the basic algorithms, my final slide goes down to this. A simple non-displaced fracture, you can put into a rigid neck collar, get an upright x-ray, then see how the patient does and follow them diligently for 3 months. And yes, they may displace, and in that case, a fusion should be done. But past 3 months, this probably does not really make sense to me. But you see in this top case, this was a case that we had to convert to a fusion because the patient displaced. And I still tell the patients, the statistics say exactly what Dr. Kramer said earlier, 50% chance of a non-union. If you have a complex fracture, or displaced fracture, or an at-risk patient who can make decisions, I would fix these early. This is a very tragic case of an elderly lady who had an undisplaced odontoid fracture treated non-surgically, was neglected. 6 months later, she came back with a severely displaced odontoid fracture that malunited in the front, and she actually chose physician-assisted suicide. So she was actually in a very sad state. She had just self-isolated from her family, and she died basically in her sleep, from what we gathered. So it's a very sad thing. For me, the symmetry of an odontoid and synapse is very profound. For me, the main decision-making has to do with the senescence of the mind, and physically active patients are probably best served with a surgical decision-making early on and a decisive fixation, just as we saw in Dr. Oskurian's case, rather than waiting around for a long time. And we have the tools now, thanks to Drs. Goel and Harms, to do that. And yes, it's a fusion, but patients in their quality of life, I didn't show that slide in our AO study, actually do surprisingly well. With this, thank you for letting us jump in for this lecture, and I want to thank Medtronic for sponsoring this. We're not getting any money from this, just don't worry about this, but thank you all.
Wow. Yeah, and I think I think odontoid fractures are so common, and it's usually in this elderly population. Do you ever? I know you see a lot of these, but is there ever a time where when's the last time you used a halo?
Not for a long time.
Yeah.
I mean, I've been here for 14 years now, or 15 years. And I think in the beginning, I put like 2 or 3 halos on, and I stopped doing them. Patients really don't like them. And our clinical results in our published in Spine, published Harvey study, were actually not bad. In the first 3 weeks, you see the failures, and you then take them off. But patients really don't like them. And
How about so let's say if you collar someone and they don't heal and they don't want to have surgery, then what do you do?
basically, flexion extension films and advise them. I mean, some patients get worse. We've all seen patients, and we have no statistics on this, who develop late myelopathy. In my other odontoid talks, I show a case of a former Viet Cong soldier who emigrated to the loser's country, that's the US, And he developed a severe myelopathy from a non-union of a type 2 odontoid fracture. He was treated in an underground hospital. It's a very evocative story.
Wow.
By East German soldiers, so he says, by East German military physicians for like 6 months in traction and something that sounded like a halo. And he had a complete non-union and cord cut off. We know that these exist. There's a lot more cord space at C1, C2, but the patients get sour results from them. They can fall, they can have cord compression. It's not an innocent bone. I don't want to come across as an overly aggressive surgeon, but this is something that needs to be watched, at least serially, with flexion extension films, and a differentiated neurologic exam is warranted.
Great. Awesome. Thank you so much.
Thank you for the opportunity.
Yeah.
Thanks for listening.
That was great. Yes. Nice job.
Thank you. Completely jammed shut this morning. It's just
Yes, I like your shoes.
Thank you.
Those are cool. Very cool.
Surely. Birthday
That's
present.
awesome.